Bom, seguimos viagem para o terceiro painel de debate, desta vez sobre medicina baseada na evidência, como combinar a prática clínica com a investigação. E para moderar esta conversa, chamo ao palco João Fonseca, diretor do MEDICINA, da Faculdade de Medicina da Universidade do Porto. Uma salva de palmas, por favor. João Fonseca é professor associado da Faculdade de Medicina da Universidade do Porto, cofundador da Medida Saúde, chefe das unidades de alergia do Instituto e Hospital da CUF Porto. Neste painel vamos poder contar com a participação de Tiago Taveira, a quem chama ao palco, por favor, uma salva de palmas. Investigador da FMUP, Tiago Taveira tem uma vasta experiência em desenvolvimento de software de saúde e já concluiu vários projetos para o Ministério da Saúde. A sua relação com a informática leva-o, de momento, a estar focado na área da inteligência artificial em saúde, um passo de enorme relevância para o futuro da nova humanidade. Vamos contar também com Marion Mafam, que vai entrar aqui por via Zoom, investigadora da Oxford University, estudou medicina na Universidade de Edimburgo. Passados 5 anos ingressou no mundo da investigação e colaborou com o grupo de estudos renais da Clinical Trial Service Unity, de onde surgiu o estudo do coração e proteção renal. Uma salva de palmas, por favor, já agora. Sim. Recebemos também por via Zoom Stefan James, investigador e presidente da Sociedade Sueca de Cardiologia. Foi pioneiro no conceito de ensaios clínicos randomizados, baseados em registro, e conta com trabalhos publicados em mais de 400 jornais de cardiologia. A palavra é vossa, ok? O palco é vosso.
Boa tarde a todos, é um enorme prazer estar aqui neste sítio fantástico, nesta cidade fantástica que é Matosinhos e obviamente neste evento organizado pelo LSM, que é de facto uma das unidades locais de saúde, eu diria uma das organizações de saúde mais importantes e que funcionam melhor, na minha opinião, que tenho trabalhado com muitas em termos de investigação e não só em Portugal. E, portanto, é uma honra estar aqui e também aqui com os meus colegas de mesa, quer presencialmente, quer por Zoom. E a minha missão foi muito feita já pela introdução dos colegas. Nós vamos começar com a Marian e vamos acabar aqui com o Tiago Taveira. E obviamente no final de cada palestra temos muito gosto que façam comentários ou perguntas, é isso que também não é só nos corredores que se conversa, também é nas sessões que se conversa e portanto temos muito gosto com isso. And I'll go to English and thank Marian for being present even if at a distance and for sharing with us your experience in real-world data, which is, of course, one of the biggest potential change makers in healthcare in the next decade. Thank you. So, if you want to share the screen and start.
Thank you very much for the introduction. Can you hear me okay?
Yes, perfectly.
Can I just ask whoever's controlling the Zoom to enable participant screen sharing, please?
You should now be able to do it.
Thank you. I'm going to just share my presentation now.
Yes, it's coming up.
Bear with me a moment. Can you see that okay?
Perfect.
Great. So it's an absolute enormous pleasure to be able to join you here from the UK. as introduced, I'm Marion Muffam. I'm a clinician and associate professor at the University of Oxford. And I'm going to take the next 10 or 15 minutes to share my experience of running large, streamlined, simple trials to answer important public health problems. So here are my financial disclosures. So we know that reliable assessment of the effects of interventions to treat and prevent disease requires two things: randomization to avoid systematic error, the allocation of the intervention by chance ensures that the two groups are equal and that the comparison is a fair test. But we also need large numbers in order to avoid random error. And clinical trials are in a crisis. Trials have become so expensive and complex that many questions go unanswered. And the studies that are done are often too small to reliably answer the question. What I want to do today is talk to you about two examples. One, a study in disease prevention, and one, a study in disease treatment, where we've tried to reinvent clinical trials to make them simple and easy to do to produce reliable answers. The first, the assente study. So we wanted to answer the question, for people with diabetes who haven't yet had a heart attack and stroke, does low-dose aspirin and or omega-3 fish oils prevent the development of cardiovascular disease, and are these treatments safe? Now, the problem is, with a long-term disease prevention study, it's extremely expensive to randomize large numbers of people and keep them on treatment with regular study visits. So my colleagues, Jane Armitage and Louise Bowman, who designed this study, which I had the privilege to work on, decided not to bother with study clinics and instead made use of what's shown on the right, the traditional British postbox. So they designed a male-based study in order to deliver a very cost-effective design. So in this study, we randomized 15,000 UK participants, only in the UK, all with diabetes, aged at least 40 years with no prior cardiovascular disease. And they were randomized to aspirin or placebo and separately to omega-3 fatty acids or placebo in a 2x2 factorial design. So this design allows us to answer two questions for the price of one. And we never met any of the trial participants in person. Using questionnaires for participants collecting data and also linkage to routinely collected healthcare data sets, we were able to achieve 99% completeness of follow-up for the primary outcome of serious vascular event and the main safety outcome of major bleed, over a mean follow-up of 7.4 years. All the study treatment was sent to the participants by post in packs that looked like this one, that were designed to go through a typical letterbox. And we collected the study information using simple questionnaires. Here I'm showing the screening questionnaire, including the invitation letter, the consent form, and some questions about medical history to assess eligibility for the trial. So using these novel, highly streamlined, direct participant methods, we recruited 15,000 people who looked like a typical, well-controlled diabetic population. Mean age 63, median duration of diabetes 7 years, most with type 2 diabetes and generally overweight, as you might expect. The main results of the study were published in 2018, and we showed that allocation to aspirin produced a 12% proportional reduction in serious vascular event. That translated into an absolute difference of about 1%. We also showed that allocation to aspirin resulted in a 30% proportional increase in the rate of major bleed, which also translated to an approximately 1% absolute increase. And therefore, in this primary prevention population, the absolute benefits of aspirin were counterbalanced by a hazard of an equal size. Therefore, we can conclude that aspirin should not be recommended for this population. We also found that allocation to omega-3 fatty acids produced no detectable effect on serious vascular event. So using this highly streamlined design, we were able to achieve the impossible. We got high quality, placebo-controlled, randomized controlled evidence on a shoestring budget and produced results which have been incorporated into international guidelines since we published them in 2008. And we're continuing long-term follow-up through data linkage of this trial participants, particularly focusing on the impact of aspirin on the long-term risk of cancer, for which there's been an evolving hypothesis. So now I want to turn to something completely different and talk about a trial of treatment in acute condition, that is the recovery trial. So in early 2020, the UK, along with many other countries, faced a public health crisis. We had overstretched health service dealing with a massive influx of patients with COVID-19 and no known effective treatments for this new disease. The only reasonable thing to do is to randomize. And I've had the privilege of working on some of the aspects of the recovery trial alongside Martin Landry, Peter Horby, and Richard Haynes. So for an acute intervention trial, the key is that trial has to be completely embedded in clinical care and super easy for the staff on the ground to do. Learning from the trials run by our senior colleagues, Rory Collins and Richard Peter in the 1980s of acute heart attack, Martin and Peter designed the recovery trial as a really simple trial. The eligibility were simply patients hospitalized with proven or suspected COVID-19. The outcome was all-cause mortality at 28 days. It was an open label trial, assigning people between treatments and usual care, provided those treatments were suitable for that patient and available at that hospital. And there was just a one-page case report form for follow-up at 28 days or discharge from hospital with extensive linkage to NHS datasets. With high-level support from government and across the NHS, the trial was deployed across all acute hospitals in the UK. And by 100 days, we'd randomized over 10,000 participants. This brought a new concern of how to ensure that we had follow-up data on all these participants in an overstretched health service where staff may not be able to have time to complete the follow-up forms. So I was asked to lead a hybrid data collection system. So on the right, we collect data in the usual way, research data specifically entered in case report forms by the trial staff. but we also collect identifiers on all the trial participants and are able to send them to central data custodians and bring into the trial database all of the healthcare data that's collected nationally about those individuals as part of their delivery of their healthcare. So you may not be aware, but when it comes to healthcare data, the United Kingdom is not so united. And we actually receive data from 5 different data custodians across the country. And we get healthcare data about hospitalization, about cause-specific mortality, about treatments delivered in critical care, data on diagnoses and medications in primary care, COVID-specific data sets, including SARS-CoV testing, and some other disease-specific data sets. So using this extensive data linkage, we've been able to get very high rates of follow-up on the trial cohort throughout the pandemic, even when patients are transferred between hospitals for ongoing care. So initially, the recovery trial used a parallel arm randomization, randomizing people to usual care versus a number of possible treatments. As the trial protocol evolved, we've moved more to a factorial design where participants can be simultaneously randomized to a number of comparisons. So this is the current design, and I'm not going to go into these treatments in detail, but just to show that if all these treatments are available at that site, and the investigator has indicated that that patient is suitable for all these treatments, potentially, if they were randomized to them, any one participant going into the trial at the moment could be randomized 5 times and included in all these comparisons. And the streamlined design, along with this factorial randomization and very rapid recruitment, has allowed us to answer a lot of questions. So this was actually the second result, which I remember being on a Teams call with Martin Landray, bringing these results and showing them to the team for the first time. And I thought at the time, I'm never going to have another moment like this in my entire career. Incredible results, showing that allocation among patients hospitalized with COVID-19, allocation to the steroid dexamethasone reduces the risk of death by 17%, with strong statistical evidence that that effect varied by baseline respiratory status, with a larger proportional risk reduction of about 1/3 among those with receiving invasive mechanical ventilation at baseline. This is a drug available in every drug cupboard around the world, and it's estimated that this treatment, as a result of this trial, has saved 1 million lives. But the important thing to remember is that we didn't know that dexamethasone was going to be effective, nor did we know that hydroxychloroquine, lopinavir, ritonavir, or convalescent plasma were not going to work. We must randomize to find out what benefits our patients. We're showing here, to date, the recovery trial has identified 4 effective treatments in patients hospitalized with COVID-19, but also, equally importantly, identified 6 treatments which don't work, which allow healthcare resources to be diverted to treatments that do. So, in summary, randomization is an essential part of good clinical care. I'm not quite sure what the term pragmatic trials actually means, but in my view, trials must focus on the things that matter, to answer the question reliably, and keep the individual participants safe. You can do that with an extremely streamlined, simple design in many circumstances. And this allows the trial to be feasible for patients and the health service. So in summary, think big and keep it simple. And I'd like to recognise the work of my colleagues in Oxford, of the thousands of participants in these two trials, and the very large numbers of staff across NHS hospitals who've made such an invaluable contribution. Thank you for your attention.
Thank you so much, Marion, for these examples of innovation actually in methodologic approach to clinical, to getting clinical evidence, and as you said, and you put it so well, to focus on what is important, which is the sound methodology, the randomization, and of course, doing the right thing, which is studying correctly big numbers and with all the available data, and as you said, also keep it simple. It's always the best approach, and understanding that the data that already is available in the system, in the healthcare systems, are of utmost importance for getting new evidence, and not only in extreme and very fast situations like COVID, but also in chronic disease and so forth. It is crucial that we gather the power of data that already exists and linking it together with methodological sound and innovative trial designs, as you showed. So I will open to the floor, and if you have any questions or comments about not specific on the examples, but on the ideas that Marion bring us and talked about, please go ahead, and you can speak in English or Portuguese as you prefer. Well, Marion, this is very important, but also very difficult yet, because it is a paradigm change from the usual very strict, very complex, expensive and more expensive clinic randomized controlled trials, especially for phase 2 and phase 3 classical designs that we are still very much into and very much used to, and it is difficult to become a part of those designs. But as you put it so well in the beginning, these are extremely complex, more and more expensive, absolutely impossible not only to answer all the questions that we need to improve the way we treat patients, but also to include all the diversity of patients that we have, that of course phase 2 and phase 3 or classic.
So because of the translation, I didn't catch all of that. So
okay.
Would you mind just in English? Because I can hear you very quietly, but I can hear the Portuguese translation. So I don't...
No problem. I was just commenting on your talk and comparing classic clinical trial designs with pragmatic clinical trials, and also other designs using real-world data together, and healthcare records data together with gathering evidence directly from patients, which were the examples that you gave and that were very, very interesting. So thank you very much, and we'll continue. Actually, we'll continue with Tiago because the other colleague is doing a catheter intervention at the moment. So, but we'll continue with Tiago to talk us also about real-world evidence. Thank you.
Thank you. Posso usar aquela? Sim. Okay, so good afternoon. First of all, I would like to thank the opportunity to be here to speak to you about a topic that for me is very dear to the heart because it is the way I found to do medicine and treat patients nowadays, which is using real-world evidence that we were very lucky to start with the vision of Professor Cristina Gavina, which was the first person to, in ULSM to start conducting this kind of studies. And so I will take some minutes to explain what have we been doing in the past years. This is all very recent, and why we think this is a paramount thing to consider to progress the healthcare system, to have better clinical outcomes for our patients, to generate evidence, overall to make the healthcare system more sustainable. And it all starts with that little word there, RWE, which means real-world evidence. And that is something that only recently, I think there is feedback if I move, so I will just stop. Very recently, this started to be discussed around Europe, the United States, and other parts of the world, because with the shift we saw in the past decades into electronic health records, nowadays, in many places in the world, we have vast amounts of healthcare data that is collected regularly for the purpose of providing healthcare, but that may capture relevant signals, relevant information, just as also Marian showed in the past presentation, that has relevance and the potential to change what we are doing, together with the evidence that already comes from the clinical trials and the pragmatic trials, just like the new shift we are seeing. And this has become a really hot topic lately, because the European Medicines Agency, the National Institute for Health and Care Excellence in the UK, the European Commission, all these relevant authorities in Europe are currently discussing how to use this kind of data at scale to frame our decisions around the efficacy of treatments, the safety of treatments, and this, of course, has drawn very recently, and you can see the nice real-world evidence framework was published 2 days ago. So this is super, super, super hot. And everybody is also discussing how can we share and use data that is on the healthcare system, because, of course, this is very sensitive data. We're not just going to use it by any means. And as most things in life, we are in a very hot time, you see, 2022, all the big news, but there are already things going on for almost a decade now. And this is probably one of the oldest groups in the world that has been trying to create a community around the world to generate evidence from this data. This is called the Odyssey Community, Observational Health, Data Sciences and Informatics, and it's a community that Unidade Local Saúde Matosinhos, ULSM, is one of the first partners to join in Portugal. And since then, many institutions have tried to come across and use their evidence to generate, use their data, to generate relevant evidence. And so, when we are discussing this topic and the experience of ULSM, we have to frame it in a big picture where more than 74 countries, more than, you see there, 2,000, it's not patients, it's collaborators, and almost about 500 million electronic health records are being in use by institutions and academia and authorities to generate evidence that can change the way we do things. And so this falls into a loop that we started to try and set up very organically. This started with, as I said, Professor Cristina Gavina, but has quickly became very big, and hopefully it will become a lot bigger. So my presentation is more about an invitation than actually showing anything that we've done so far. That fits very well the framework that everybody feels that we need in institutions. We need to plan, and we plan, I would say, better or not so good, but we plan for a long time. We measure things for a long time as well, so this is where we get data. This is the data that we collect regularly in healthcare centers, hospitals, etc. And now we are in the point of using being able to analyze this data to generate knowledge. And the important part here that I would like to stress is this knowledge is local knowledge. And the shift we see in science and in clinical medicine is also going to take place, like we see in other areas, to generate knowledge that is useful for the institution to take care of their patients according to their needs. And this creates opportunities for improvement, local improvement, change the ways we implement processes or policies or other parts of the healthcare system. And hopefully we can repeat this once we get the hang of it many times over. And of course, this is something you are familiar for sure. We do this formally or informally in very different scenarios. The important thing about this is, as Marian was also putting it before, is doing this in a cheap, expandable, scalable way that does not overburden everybody in the system. Because all healthcare professionals, today they look very happy, but I'm also a family physician, and we know how difficult it is to work and to be able to put up with all the demand that the system and all the challenges that we currently have. So we want to make sure we can do things without asking healthcare professionals to put extra time. And so this is what we started, and this is one of the first things we did with Professor Cristina Gavina and other colleagues about using all this data that is available at ULSM to try and find out who are the patients with heart failure, chronic kidney disease, and cardiorenal syndrome. And what we found very interestingly, and this was not described before, even at the global level, we saw extremely high excess risk when these conditions co-occur. And of course, we are talking about cardiovascular death. Maybe it's not very easy to see on the screen. But this means that there is a set of people that have tenfold chance of dying by cardiovascular disease in this model within 1 year. And this is from our institution. And so if we can find who these people are, if we can create protocols to act upon them, maybe we can change the quality of care, maybe we can change the life of people in more effective ways. And so this is what makes us so happy, is that we are generating local knowledge that can benefit everybody. And again, this is not new at all. This is the best example that is implemented for decades, which is exactly what I'm suggesting to do and ULSM is doing, the hospital infection and control. Actually, in infection control departments, we generate evidence, local evidence at the department about which bacteria are resistant or not. We feed that information up the system until we get to the authorities that can, and patient groups and societies that can make guidelines. And if we just change infection control by real-world evidence, we get a very nice picture of how the scientific community is thinking with this regard. And the ULSM is one of these thousands institutions in the world, one of the few in Portugal, that is going into this way of thinking and putting the evidence into the service of people. Of course, this also has scientific value, of course. The evidence we generate locally can be relevant in other places, and of course, this evidence is scientifically generated. And we have been very enthusiastic about recent publications we have had in multiple areas of collaboration. At this point, we are working with almost 50 different people around different centers in Europe and the US. We have colleagues in Korea. So a lot of countries, a lot of projects. We have presented many of these results in international conferences, many papers, some publications, and even prizes. One of them was last year, Professor Carlos Araújo received from the Portuguese Society of Nephrology. Actually, it was this first paper. And we also have with this the opportunity to generate evidence at scale with centers around the world. And this is one recent publication with 12 other countries, a multinational study in which Portugal collaborated through ULSM. And so I would like to show you a bit more how what this looks like. And for me, when I think about seeing a patient, some things, if I have known this information, I would have treated my patient in a different way. And what we see here is evidence of stratifying patients by cardiovascular risk. This is always ULSM. You see there 20 years of data, amazing. And you see something not so amazing on the dark red line, which is a very big number of people having an event very soon, within one or two, within the beginning of first year. And so we found a need to change, to adapt the way we are providing care to help these people. And we have done this in this case of cardiovascular disease, which is a Latino study, but this can be done in any area. Other things we found very interestingly is that the very high-risk patients, they are very different. There are actually three different groups. And so this is what the European Society of Cardiology recommends us to think about when we see very high-risk patients. It's one big bag. And we saw that in ULSM, that is not the case. There are 3 small bags. And so we need segmentation of care for these people. But we discovered this just 1 year ago or less. So when we think as clinicians, we see here immense opportunities to change. And the other part of the cycle that I was mentioning is improvement. And so now that we know all this information, we need to try and think of ways to change the system. And the change should also be systematic. It should be a clinical research question. We should not just decide to go one way or the other because it seems right or wrong. We should study it like we study the efficacy of a treatment. And so at this point, we are trying to create a tool to help physicians quickly find the relevant information about these very high-risk patients, and hopefully this little pop-up that you see here will be enough to, within a few years, reduce the number of events, cardiovascular events, reduce death events, reduce cost, reduce healthcare resource utilization. And so this is the big picture. ULSM can plan since it was created in 1997. It can measure data since 1998. We are analyzing in the context of real-world evidence since 2 years ago. We are trying to enter in this area of feeding in the knowledge into the system, and hopefully by 2025, maybe earlier, maybe later, we will be able to see how impactful this was. And as a clinician, this way of thinking really gives us additional enthusiasm to become, to feel that we can do better and become better, and the system can become better. And just for the sake of giving a bit more context, OLSM is also integrated in the European Health Data and Evidence Network, which is a subgroup of the Odyssey community. In Europe, there are already about 140 data partners. In Portugal, there are 8 centers already thinking like this. OLSM was the first one, and it was Professor Rosa Maria Príncipe who had the idea of going into the Eden community, and that was really brilliant because this puts OLSM into a network of partners that can study very different types of diseases, challenges, and you see here from the clinical topics that we are currently developing, from cardiovascular, cancer, COVID, violence, to study types that go from prevalence and incidence estimation to patient pathway definition, identification of missed opportunities, and that rely on very different methods of data analysis, many of them quite crossing edge. Of course, this is all possible because we find ways with the help of the community and the help of the partners, and I see there one guy that was responsible to make sure this all happened, Tiago, José Castanheira, Jaime, Professor Cristina Gavina, Professor Carla, and other colleagues, that we have conceived ways to make sure all this is done inside the hospital. So data never leaves hospital anytime. Nobody has access to data anytime. We just make sure that there are the correct tools to process data where it is. And so this is a very enthusiastic period, I believe, at least for me. I think you feel that. But what I would like to also extend is the invitation for all healthcare professionals, management, everybody that is in one way or another involved in providing care, invite them to join this kind of approach. This is the slogan of the Odyssey community and the slogan that we need to create. This is all aboard. This is not something for the scientist or for the guy that only thinks about the papers. No, no. This is firsthand about the people that provide care. The people that provide care, they know the necessity, they feel the pains, they know the patient, they know how the system evolves. So they are the ones that have to lead this. And so the symposium was just last Friday. I went there real quick, and the idea is all aboard. And I think that if we are indeed all aboard, we can make healthcare look pretty much like this beautiful picture here from Matosinhos. So thank you very much.
Thank you, Tiago, so much. It is such pleasure to see how real-world change can be made at our institutions and here in the northern region and Porto area. So it is great that you can show us that, and then you explain us that, of course, there are critical aspects like security and privacy and so forth that are very well dealt with, and that this new type of approach is methodological sound, as I previously said, and it is what we have to move forward. Other approaches are either guesswork or continuous to bang our heads in the walls, or even worse, put our heads in the sand, which is something that we often do anyway, too much. So I believe that, well, first of all, I don't know if Marian or Stephen are present. No, so we can change to Portuguese, it's just obrigado. Antes de mais, peço desculpa de ter estado a falar em inglês, não é que, como perceberam, não é uma língua que falo direito. mas pronto, era por termos sempre esta lusitana maneira de sermos simpáticos com os nossos convidados estrangeiros, mas acredito que sendo o tal conhecimento local, sendo o vosso trabalho, sendo o vosso benefício direto, que possam ter perguntas aqui para o Tiago e comentários a fazer. Por isso, por favor, não deixem que a presença da administração vos iniba e, portanto, avancem. Eu posso ficar aqui a tarde toda.
Nós vamos conseguir terminar a sessão a hora, está-me a parecer.
Pronto. Não, eu quero... Pronto, sendo assim, eu não vou fazer mais comentários. Já perceberam que eu também sou um grande fã destas áreas. Há bocadinho no início falei da OLSM como uma instituição de topo e não me expliquei melhor. De facto, quando é possível fazer em Portugal trabalhos deste género com dezenas de instituições, e isso aconteceu já por 2 vezes no meu trabalho mais pessoal, desde 2017 para cá, mesmo durante a pandemia, e por isso é que eu posso afirmar que a OLSM é mesmo dos melhores com quem eu trabalhei, e por isso é um gosto em particular, além também de ter muito gosto que o Tiago esteja no departamento que eu atualmente dirijo, de poder estar aqui convosco e de alguma maneira também vos felicitar pelo vosso trabalho e pela vossa organização. Obrigado.